Hey guys, welcome back to ST3 Hacks. And today is a big topic. It's knee dislocations. Just before we get into it, a few housekeeping points. If you haven't checked out my website, it's aniketbharadwaj.com. It has a lot of free guidance and resources for how I approach the interview, along with some options to get my cheat sheets and sign up for interview practice if you want some last minute one-on-one grilling. Now, coming back to the episode, knee dislocation is the disruption of the tibiofemoral joint. It's rare, but it's catastrophic, okay? And it's a surgical emergency. The risk isn't just the dislocation itself, it's the vascular and neurological injury that comes with it. Let's talk about the pathoanatomy. And the classification that you really need to understand is the Kennedy classification, which describes the direction: anterior, posterior, lateral, medial, or rotational. Rotational dislocations have the highest rate of vascular injury. The popliteal artery gets twisted and torn. There's also the Schenck classification, which describes ligament involvement by numbers. So type 1 is ACL alone, type 2 is ACL and PCL, and type 3 adds the medial collateral, and type 4 adds the 4 major ligaments, the lateral collateral as well. The higher the Schenck number, the more ligaments are torn, and usually the more severe the injury. Now, the critical anatomy. The popliteal artery is at risk in 25% of knee dislocations. Why? Because it's fixed proximally to the adductor hiatus and distally as it enters the soleal arch. So that real niche point is important, and I would mention that if you get this station. There's no give or flexibility in the popliteal artery because of those fixations. When the tibia dislocates relative to the femur, the artery gets stretched, kinked, or torn. You get arterial disruption, occlusive thrombosis, or intimal tears. An intimal tear is insidious. The pulse might be still palpable when you examine the patient, but the intima is damaged and thrombosis is basically incoming. That's why you can't rely on pulses alone for your examination. The common peroneal nerve is also at risk. Traction injuries occur in about 1 in 4 patients. The nerve runs around the fibular neck and gets stretched when the knee dislocates. The clinical signs that should raise your suspicion for dislocation are specific. Hemarthrosis with extensive bruising and swelling suggests joint capsule disruption. A small effusion means a capsular tear usually, but a massive hemarthrosis with swelling that extends up the thigh and down the calf tells you that something has happened. Recurvatum on passive extension is a sign of knee hyperextension injury. If you gently extend the knee and it goes into recurvatum, the knee bends backwards. This suggests that there's major ligament disruption, usually from the extensor mechanism. Gross varus or valgus laxity when you assess the knee, not subtle laxity. Gross obvious deformity tells you collateral ligaments are torn. And then you've got the dimple sign, and it's important that you really understand what that is. It's anterior-medial puckering of the skin where the femur has buttonholed through the quadriceps. It's a sign of an irreducible posterolateral dislocation where the soft tissue has gotten trapped. This is a red flag because it threatens skin necrosis, and you need to reduce it in theatre, not in A&E, okay? Let's move on to our triple assessment. So examination, you got to do a thorough limb function, a look, feel, move, neurovascular assessment. This is your baseline and most important data point. You've got to know the innervation. The tibial nerve gives motor innervation to the plantar flexion and sensation to the sole. The superficial peroneal nerve gives motor supply to eversion and sensation over the lateral aspect of the foot. And the deep peroneal nerve gives motor to dorsiflexion and sensation to the first dorsal web space. You've got to document all of these thoroughly before reduction. Pulses, check the dorsalis pedis and posterior tibial pulses. The popliteal pulse is unlikely to be palpable anyway. It's deep, so don't rely on it. Check the capillary refill time. Feel the foot. Is it warm or cold? This is crude, but it tells you about perfusion. A cold foot is a red flag, obviously. And document all of this carefully. You need a before and after reduction comparison. Investigations, you want to use a handheld Doppler and calculate the ABPI and know what the ABPI is. It's the ankle brachial pressure index. This is your key test. An ABPI greater than 0.9 suggests adequate perfusion. You can admit them for observation for 24 hours and then order the MRI. An ABPI less than 0.9 suggests arterial injury. You need vascular imaging and vascular surgeon input immediately. Now, the critical point here is pulses can still be present with intimal injury. A normal pulse does not rule out vascular injury. That's why we're using a Doppler and ABPI, not just our fingers. Now, if the ABPI is abnormal or you have any clinical suspicion of vascular injury, you get a CT angiography of the lower limb to check the popliteal artery. You're looking for thrombosis, dissection, or any other sort of injury. The threshold for CT angiography is very low. If the initial assessment looks okay, you should still consider it. You should already have your plane radiographs, your AP lateral orthogonal views. The BOAST guidance is that if you're doing a CT, get a CT angiography at the same time without repositioning. Let's move on to our initial management. So, this is a surgical emergency. You need to get the knee reduced quickly in A&E with appropriate sedation and analgesia, reduce the dislocation, correct the medial and lateral translation using principles of traction and countertraction with appropriate assistance, and ensure to mention that you would check neurovascular status before and after reduction. After reduction, place the knee in a cast with 20 to 30 degrees of flexion because it prevents posterior subluxation of the tibia, and full extension would allow the tibia to slip back, so that's why we don't want that. Observations, you want to admit this patient even if the pulses are present, even if the ABPI looks okay, even if the Doppler looks okay. Why? Because intimal injury can progress to thrombosis over hours, so you need hourly neurovascular observations, document the color, temperature, CRT, pulses, and neurological status, and have a close eye on them, and go and say that you personally review them overnight, because this is where things can be missed. Moving on to vascular injury management. You should say that I'd manage this patient as per BOAST guidelines on arterial injuries. I'd request a vascular review, and they may consider an on-table angiography to reduce warm ischemia time, aiming for revascularization within 4 hours. You should say that there should be consideration of a prophylactic fasciotomy due to the risk of compartment syndrome, secondary to reperfusion syndrome, if the warm ischemia time is more than 6 hours. Moving on, importantly, there is a procedural order. This is important for a specific sequence of actions. Firstly, you want to have temporary vascular shunts to restore perfusion immediately. This is your priority to get blood back to the foot. Shunts are basically temporary conduits that restore flow while we sort out the skeleton. Number 2, you should have skeletal stabilization with a spanning external fixator, 2 Schenck pins in the tibia and 2 in the femur, connected by bars in a stable rectangular construct. This holds the knee reduced while the vascular team works. You can add more pins and bars based on your need for stability. And lastly, third, you want a definitive vascular reconstruction. Once the skeleton is stable and warm ischemia time is minimized, you do the vascular repair. And this may be in the form of a vein graft or reconstruction. Throughout this, you need to ensure that the patient is adequately heparinized. This prevents thrombosis while we're working on the patient. Let's talk about the fasciotomy consideration. If warm ischemia time has been prolonged more than 6 hours, you should consider a prophylactic fasciotomy. This is because reperfusion syndrome causes swelling and compartment syndrome risk, and opening the compartments prophylactically can prevent secondary compartment syndrome and subsequent limb loss. So it's really important that you always have this at the back of your mind. Moving on to post-operative management. In the early phase, you want to arrange an MRI at 2 weeks. By then, the external fixator usually comes off. You get the patient weight-bearing and mobilizing, assuming the vascular team is happy, and the MRI shows you the extent of soft tissue and ligamentous damage. Then you need specialist discussions in a clinic based on the MRI about soft tissue repair options. This is where your knowledge of knee ligament reconstruction comes in, but that's beyond the requirements of St3. The key principle here is that you have a staged, delayed approach. In 2017, a systematic review showed that staged knee dislocation repair has a lower risk of knee stiffness than acute comprehensive repair. You don't fix everything at once. You stabilize, you assess, and then you come back later. The typical sequence of repair is usually PCL and MCL first, and then you come back to ACL. This is because the PCL and MCL are easier to repair acutely, and getting those stable improves the biomechanics for later ACL reconstruction. Special situations. So if you have a irreducible dislocation, if you see the dimple sign, which is what I've mentioned earlier, the anterior medial puckering of soft tissue, this is an irreducible posterolateral dislocation. The femoral condyle has buttonhole through the quadriceps and you can't reduce it in A&E. This needs to go to theatre. Get the patient to theatre, inform your consultant, inform CPOD, ICU, make an appropriate incision, release the trapped soft tissue, and then reduce it. It's urgent and you need proper exposure. Amputation decisions. If revascularization cannot be achieved and the limb is unsalvageable, amputation might be the right call. This is a dual consultant conversation between orthopedics and vascular surgery. The patient may need to be made aware of this possibility early, and if early amputation is decided, it needs to be documented by the 2 consultants clearly, as this is a very important legal documentation. In summary, knee dislocations, are a surgical emergency. You need to recognize it with key things like hemarthrosis, rickebatum, gross laxity. Reduce it in A&E unless it's got the dimple sign. You've got to assess neurovascular status before and after. Learn how to use the ABPI, and you can describe it in two or three sentences. Learn the vascular management. Admit the patients overnight with hourly neurovascular observations, even if you're a little bit concerned about the popliteal artery. Understand why we get the MRI a little bit later in the staged ligamentous repair. So that covers the essence of knee dislocations, and I wish you well, and we'll catch you in the next one.